Well, I mean, ostensibly, you're not going to have that many patients who are on first-line IO, but we're certainly treating some, whether it's because they're part of a clinical trial or because you really felt like you needed a response. I think a fraction of patients are getting IO in the first line off-label. And at that point, I think you're going to shift to a TKI because that's really the only thing you haven't utilized at that point. Whether you start with sorafenib, as a quasi first-line TKI or lenvatinib, or you just go straight to cabozantinib, say, because their data after IO, I don't think we know. I mean, I think most of the patients are probably going to go to one of the first-line agents like sorafenib or lenvatinib. But I think you could make an argument that there are data for cabozantinib, and that's probably what you should be using. Truth is that in the minds of most oncologists, and I'm going to speak for most oncologists here, I think most oncologists feel that TKIs are somewhat interchangeable, and the best data that we've had in the first line is from lenvatinib, and in the second line, I think regorafenib is pretty good, and I think cabozantinib is pretty good, and I think for the patients who have those high AFPs, ramucirumab is now an option. I don't think any of there's no clear winner at this point.